Boulder, Colorado.
Sorry about that.
We're an investor and an accelerator. So Elliot is wrapping up the end of his 13-week accelerator this program this summer. We have graduated over 2,500 startups and 6,500 entrepreneurs that have grown their companies to a market cap of around $25 billion. And we have a Kansas City chapter, if you will. So if you see great companies that might be a good fit for Techstars, please send them our way. But I'm so excited to present Elliot Arnold with MoodSpark today. Elliot is a serial inventor and entrepreneur. He cut his teeth in the defense, technology, and electronics components distribution industries. He developed and sold a digital assistant to Click, which is Tableau Software's largest competitor. And what you're going to see today is where he is with MoodSpark, which is the only mood improving digital companion designed to detect sadness and uplift with emotional memories, personalized conversations, and video visits from friends and family. We're super excited about what he's doing, and I'll just hand it to him to tell his story. He's got great traction, and I'll hand it to you, Elliot.
Thanks, Maria. Good morning, everybody. Thanks again for taking the time to meet with me. Wanted to give you a little bit of an overview on the company itself. We were founded in 2020. The company was born out of explicit need. My father suffered from loneliness coupled with dementia, and it was lethal. And it's a big problem, as most people on this phone know. More than 20 million American seniors and their loved ones suffer from loneliness, anxiety, and depression. And it's a very expensive problem in medicine. 300 billion a year is spent treating the problem. So, and it's personal to me. I saw my dad suffer, and I realized that there was no technological means of keeping my father happy and detecting when he was sad. So I started the company to solve that problem. And our mission and our reason we're in business is essentially that we believe the human spirit is cared for by sparking the emotional memory. That's really a cornerstone of our capability, is surfacing emotional memories and detecting emotional responses to those. We've assembled an A-list team that firmly believes that the human spirit is cared for by sparking the emotional memory. My co-founder and CTO, Martin Bukowski, he and I have been working together for a number of years. In my last business, Martin led our decision science practice on the West Coast. We worked with companies such as UCSF Hospital, Varian Medical Systems, and Apple Computer. We built predictive algorithms for Varian Medical Systems, oncology systems, and Martin led that practice for us. So very capable technical co-founder and a very savvy business person. So it's a very powerful combination. And we've assembled a really crack advisory team. My lead investor, Steve Peirce, is a serial entrepreneur. He was the youngest CTO of Sprint and has had multiple exits, former CTO of Nortel Networks, founded Bay Networks. And really, I call him the grandfather of the Internet of Things, because he built, he built the cornerstone of home automation and Internet of Things fabric at a network level. So it's very exciting to have him as a partner and lead investor for us. I'm going to be talking to you today mostly about the research that we've done over the last year and where we need some assistance. And that research was really rooted in guidance and direction that was given to us by Dr. George Grossberg, who's the Samuel Fordyce Professor of Geriatric Psychiatry at St. Louis University Healthcare. Dr. Grossberg's active on our advisory board. And I approached Dr. Grossberg about a year and a half ago with the idea of this company and our hypothesis, the hypothesis that I initially discussed with Dr. Grossberg, which led us into our pilot project that we developed at Del Mar Gardens, was is tapping into the emotional memory a way to slow cognitive decline in Alzheimer's and dementia patients, or those seniors experiencing anxiety or depression combined with dementia or some form of cognitive decline. And he thought that was a very exciting research hypothesis to focus on. And he directed me towards a more immediate area of research that we ended up publishing for the Alzheimer's Association, which was specifically around a non-drug-based form of mood management. As Dr. Grossberg and I started talking about the problem and talking about the state of the art relative to non-drug-based mood management, which largely relates to occupational therapy and physical therapy related activities within this population. He kept saying, Elliot, there's really not a lot of technologies, to help manage patients' moods in times of need. And so we decided we wanted to study this. And in partnership with Del Mar Gardens, we launched a pilot study in November of last year. And the thesis of that study was really to focus on digital reminiscence therapy as a means of controlling mood. And one key aspect of this study, which is really core to our technology, is not only our ability to spark or surface emotional memories for subjects, but also to capture those emotional responses by way of artificial intelligence and sensors on board our device. So our device is essentially a hardware device paired with a family application. Family members upload, they build a basic biographical profile of their loved one. They upload, connect, and share content, and notifications and suggestions, keep them informed and engaged. And MoodSpark goes to work by detecting low-level signals of sadness or stress experienced by a patient and intervenes with personalized conversational cues or content suggestions designed to distract and redirect the patient away from an anxious moment or a depressed moment, which in this particular population, in the population that we studied, which was a spectrum of Alzheimer's and dementia patients. We had a few. It was a small N number. We only had 6 patients in our study as part of this pilot. So there's a lot of follow-on work we need to do, but to expand the statistical significance of our data. But it was enough to be published by the Alzheimer's Association. We got some good coverage for it. And some of the learnings that I think are important for this audience are, number one, we proved that we can improve mood. We proved that we can redirect a patient in sundowners experiencing an anxious or depressed episode by way of triggering emotional memory recall and capturing that resultant state. And you can see in our AI components here, the before state is on the left. So this would be sort of the stasis. And on the right side of the page is the happy state, or the recognition state of affect and positive mood enhancement. And so this was pretty groundbreaking for us to be able to capture this both with microphone recordings as well as with visual facial recognition software. In addition to that, we found there was a significant amount of ancillary benefits that were derived from the family members themselves. This was actually an interesting byproduct of our study that we hadn't originally scoped for, wherein the family, and by the way, we launched this study right before COVID, and then we had patients working with our technology during the early part of COVID, literally right before lockdown and then during lockdown. So there was factors there that were really significant both for families and patients just in terms of access and escalated isolation. And to that point, the family members really benefited because it kept them it kept them close to their loved one when they couldn't show up in person. They felt like they were contributing to their loved one's care. They got a better impression of the facility's level of care. The facility folks, so we had an occupational therapist on staff there and a licensed clinical social worker on staff there that were observing reactions as well. So we got a lot of observational data, both from our social worker and the OT on staff at Del Mar Gardens. And the evidence that they shared with us and that they collected with us was really it was really exciting because it freed them up to perform other activities. The using our technology was engaging for the patient and didn't distract. It didn't. They didn't lose interest. As a matter of fact, we were able to capture when a patient lost interest with gaze detection. So if a patient looked away, as an example, or moved away, that's obvious sign that the patient wasn't engaged. And we didn't see a lot of that, but we were able to observe it on a couple of occasions. But the caregivers actually really benefited from this because it allowed them to engage with their patients in a lot more personalized manner, and it was fun. It was really an evolution to a traditional reminiscence therapy approach, which, for those of you who don't know what reminiscence therapy is, essentially it's sitting down with a photo book and asking a patient with cognitive decline, what are they observing in the photos? So it's having a dialogue about their lives and surfacing these past life experiences as a means of managing mood and stoking the self-esteem of the patient. So our research was beneficial, and we've been working with Del Mar Gardens on a follow-on study, and I wanted to introduce our channel strategy to this group because this is where I certainly, and the company could certainly use your help relative to growing our business and helping us expand our reach to care for more people in the community. We are targeting 3 different types of channel partners for an affiliate program: home care agencies, assisted living facilities. We already have a relationship with Del Mar Gardens in St. Louis. And I'll talk to you guys in a second about a follow-on study that we're working on and that we could use some help with. And then medical groups. So I had some very interesting conversations over the last month with Wisdom Tree, which is it's a boutique geriatric medicine clinic, medical group in Boulder, Colorado. And one of their physicians runs, she's chief medical officer at Boulder's largest assisted living facility. And we've gotten a lot of interest from physicians and geriatricians as well, referring this product into families as a means of keeping families connected and non-drug-based means of mood management. And so I wanted to just be very upfront with where this group could help us as a company. We need to expand our affiliate relationships with channel partner targets that I just mentioned. So any introductions to prospective affiliate partners would be extremely helpful for us. So home care organizations, assisted living facilities, or private practices focused on geriatric medicine. We're also looking for physicians and research partners to support a cost study focused on reducing caregiver stress and turnover within assisted living facilities. This is a key component. One of the things that we recently talked to our partner Del Mar Gardens about is What are some of the triggers of turnover? What's motivating turnover? And it's and within the cognitive, the geriatric population, and the primary population that they serve, it's largely due to high stress redirections. And for those of you that don't know, a redirection is essentially taking somebody who's having an anxious or depressed episode and moving them away from focusing on that. And so, and our technology is purpose built to essentially perform that redirection and distraction away from that anxious moment. So we're really looking to prove out the value of using our technology as a means of redirection, thus reducing caregiver stress. So any leads you can give us on physicians that are studying this, or research partners that could help us with grant funding. Del Mar Gardens has made a commitment of patients. So we have a really large patient population size that we could actually involve in this study sooner than later. So any help there would be very appreciated. And then lastly, we're preparing for a seed investment round, and are looking for potential investors. At this point, I'd like to open it up for questions.
Thanks, Elliot. Tell me a little bit more about how the solution benefits the caregiver in terms of lowering stress and turnover, that aspect of it. What comes to play there?
Right. So a good question. In the Alzheimer's and dementia population specifically, and these could be patients living at home or in facility, certain times of the day, the sundown tends to be one of the most anxious times of day for this population. And as a result, anxiety goes up, and or depression goes up. And as a result of these escalating mental factors, it's hard to redirect a patient away from those anxious moments. And so with MoodSpark, our digital assistant, our companion, is designed to detect those moments of anxiety and offer conversational cues and content suggestions to essentially distract the patient away from those moments of anxiety. So if you think of in an anxious moment, where you can't get yourself out of the doom loop of anxiety or depression, where you may be missing your wife, your dead wife, or not knowing where she is. Sparking the emotional memory by saying, hey, we've got a great family photo album for you to check out with some Beatles. We noticed that you might be sad. Come check this out. Just might be enough to distract the patient away from that anxious moment. And it's a digital intervention, so a caregiver doesn't have to be involved. So our objective is to reduce the amount of human intervention at the point of these anxious or depressed moments. Does that answer your question?
Yeah, so you're taking the burden off the caregiver for managing those instances.
That's right. And a reduction of 10, 15, 5% is a significant reduction in caregiver burden, because this is a major factor for their own stress. It's also a major factor for families as well.
Okay. How does a detection actually take place? So
detection takes place privately and discreetly, watching and listening. So we're using, presently we're using onboard camera and microphone sensors. And we have pattern recognition built into the camera and the microphone to detect signals of sadness, stress. It could be crying, it could be repeated questions, it could be moaning. These are all sounds that we've established pattern detection for, as well as all of the facial cues that we could pick up when the subject gets in front of or near the camera.
Okay. Others in the group have questions. Please bring them forward.
Yes, one question. Have you looked at any VR or AR, devices that would help with this?
We have, and our initial patient population, some of the challenges with the initial population that we have studied is there's a big reluctance to wearables.
Yes.
Anything that is discomforting or unfamiliar to the patient, they tend not to like. So we've intentionally tried to limit wearable technology for the initial subject population, namely the Alzheimer's and dementia population. There's application across a broad spectrum of patients suffering from anxiety, depression, or cognitive decline. But because we're initially focused on those with cognitive decline and coupled with loneliness, wearables tend to be kind of an aversion for those subjects.
Okay. Yeah, right now, a 1 pound device in someone's head is not going to be comfortable. But in the next 6 years, you're going to have smart glasses that will take away that clunkiness.
Yeah, absolutely. Yeah, it's an interesting field. There's a lot of work being done on AR and VR for in silver tech right now. So yeah, I mean, we're keeping our eye on it, certainly.
Okay. Thank you.
A new frame of reference for our deliberations in silver tech. Other questions from the team? I might ask, how have you been able to make contacts through the accelerator? Has that been helpful to you?
Yes, the accelerator, Techstars is an amazing experience for a founder. Extremely supportive network of people, incredible curriculum that they run founders through over this 13-week period, and really great door opening experiences. It's been it's really reduced friction in terms of getting in front of the right people and having the right conversations with a lot of credibility behind you. It makes all the difference in the world.
Right. When is your demo day? Are outsiders welcome to that?
Yes, outsiders are welcome. There's a sign up that we can share with you. I don't know if we're at capacity or not, but it's next Thursday. It starts at 3:00 next week.
Okay. And would there be a sign up on the Techstars page? Is that where we would find that?
I think so. I think we can circulate it out to the group after the call.
Okay, very good. Any other thoughts from the team? I think that we started out really many years ago with a focus on seniors in the work of Casey Digital Drive, and so this is kind of a nice follow through. I wonder if others have any further thoughts. Okay, well, Elliot, thank you very much. That's it really seems like you've made some great progress here, and to be able to automate these kinds of things is really remarkable. And I think anybody who's had seniors in under care would appreciate the value of this kind of thing. I know in my own particular case that ability to feel close to what was actually going on was very, very important to me, and any additional tools to make that happen are very welcome. So thank you very much for presenting to us today.
Thank you very much.
All right. Now I'd like to just give reference to Matt Heelan of Illumisoft, who alerted us to the great work that Dr. Mark Clements is doing, and just kind of by reference to him, and then introduce Dr. Clements to speak to us about the innovation going on in his field and how he's kind of organizing things around that to really drive care and better outcomes in type 1 diabetes. Dr. Clements?
Thank you. And I'd also like to thank Matt for alerting me to this venue and the opportunity to talk to all of you today. So let me make sure that you can hear me okay and that you can see my screen.
I think we're good to go.
Excellent. Okay, so I'm going to talk a little bit today about type 1 diabetes care. For those of you who don't know me, as I mentioned earlier, I'm a professor of pediatrics at Children's Mercy. I provide care for youth with diabetes and the host of other endocrine problems. I've been at Children's Mercy since 2003 when I started my residency training right out of medical school. So we'll jump into it here. Also for those of you who don't know, Children's Mercy provides care at multiple sites across the states of Kansas and Missouri. Our diabetes center specifically provides care to 11 different sites across both states. And we have a catchment area that is essentially a 3 hour to 5 hour radius around Kansas City. So the problem that we're tackling in pediatric diabetes care is that blood glucose control is essential to maintaining health and preventing complications for the rest of the lifetime. There's a hypothesis called the metabolic memory hypothesis that says that poor control early in the course of disease stays with you for the rest of your life in terms of the risk elevation. You can never undo it. So if you look at blood glucose control in this graph exemplified by the biomarker hemoglobin A1C, you can see that we've got a real problem. At the bottom of the graph is the hemoglobin A1C of 7% that is the target for diabetes treatment. We want everybody's A1C to be less than 7. And if you look at the median A1C across the lifespan in people with type 1 diabetes, and these data come from a national consortium of 84 centers called the T1DE Exchange that I chaired for 3 years. This shows that adults are doing much better than kids, and even adults are not generally in control. And if you look at the left hand of this curve, you can see that in youth, the hemoglobin A1C is not only elevated, but after diagnosis, it continues to rise and rise and rise to a peak of above 9. And then it takes until about age 30 to settle back down into the adult care pattern. Another way of thinking about this is to say that only 18 to 22% of our youth in US diabetes centers are meeting their goal for blood glucose control, which is just a terrible outcome, and we need to improve it. The other problem that we have is that we have a limited number of treatments. In diabetes care, as in many chronic disease, we tend to focus on the drugs and devices that we use to treat disease, and not a lot of attention goes into the behavioral, educational, or care delivery interventions that really can serve as wrappers to help somebody be more successful with their disease self-management. If you look in, across business, we've known for some time since the dawn of the information age that we can enhance life, we can enhance quality of life if we cater not only to the majority population, but also to the long tail in the marketplace. And so I think in medicine, we're achieving a place when you hear people talk about personalized medicine or precision medicine, where we're really replicating what we've known in entrepreneurial circles for some time, which is that there is always a long tail in the marketplace. Not every product works for every person, and that there are niche products that can find a home and that can improve life and quality of life for many individuals. So, when I was a kid, my parents drank Maxwell House, my grandparents drank Folgers, and those were the only two coffees available. But many industries, including the coffee industry, have learned to cater to the long tail. And, the question that I am constantly asking myself is, why in medicine do I still only have a handful of treatments available that are codified and programmatic in our diabetes care? And does this lack of diversity in treatment options, particularly behavioral, educational, and care delivery interventions, lead to the health inequities that we see? Are the engineers that are designing devices, for instance, designing for the bulk of the marketplace, but not thinking about those who might have health literacy or numeracy or issues engaging with technology? So here are a few fundamental questions we've asked. What if we could get in front of poor outcomes and treat them before they occur? What if we had more than Folgers and Maxwell House to offer? What if we could move care out of the clinic and instead provide care delivery in microdoses in daily life? And so we have created an initiative that is a partnership between our institution at Children's Mercy and a data science firm, SIFT, and our funder, the Helmsley Charitable Trust, that has provided generous funding for us to launch this initiative. And the Rising T1DE Alliance is really about answering the questions that I posed above. So what's our vision? Our vision is really to improve outcomes and the patient experience and the value of diabetes care across the ecosystem for all stakeholders involved. And we want to do that by forecasting outcomes, by introducing innovations in care in rapid small tests of change, rapidly iterating on that, and then broadly disseminating what we learned to other diabetes centers. As a bit of background, I mentioned drugs, devices, and biologics in the top line here. Those are the primary treatments that we think about when we think about medical therapies. But we all know now, after the last 20 years or so, that behavioral and care delivery interventions, which may be delivered in person or may be delivered through a mobile health or digital health wrapper, can really enhance a person's success with the drugs, devices, and biologics that we provide to chronic diseases. We also know that the traditional clinical trial is very expensive, takes a long time, does not often teach enough about which intervention works for which person. It's not always guarantee real world success of a therapy. And finally, that those bottom line interventions, the so-called wrappers that I mentioned, they often don't require clinical trials before test implementation because a lot of them are based on evidence-based principles and they're low-risk propositions in clinic. And then finally, as a bit of background, I just want to mention that I take issue with the definition we've been walking around with for the last decade and a half of personalized medicine that says that medical care can be tailored to the genetic and molecular profile of an individual. And I think it's time to update that definition to really encompass behavioral interventions. So the new definition, I think, should be that medical care can be tailored to the predicted outcomes and unique response of an individual to all candidate therapies, again, including mHealth, behavioral, and care delivery interventions. And that really recognizes that precision engagement is important to precision medicine. So what are we doing? Well, very few diabetes centers track population health or use risk-based management protocols, and no diabetes center uses all of their available data effectively. So we have created what I think is a relatively simple mental model, which is that we have a clinic population of over 2,100 individuals. They have diverse risk for any given outcome we would like to prevent, and they have presumably diverse responsiveness to any particular therapy or intervention we put in front of them. So we have decided to take all of the electronic health record data, including all discrete data, free text clinic notes, all of the personal diabetes self-management device data, any personal wearable data, consumer grade personal wearable data, and any patient reported outcomes data that we obtain in the due course of clinical care, and to put those through model development to develop risk prediction models for outcomes of interest. And then we stratify the population based on those predicted outcomes. While a lot of my colleagues around the country are stratifying populations by risk based on retrospective outcomes defined from Boolean searches in the medical record, we're looking ahead and forecasting to define the risk. And then we're basically taking those behavioral mHealth and care delivery interventions. We're curating those from colleagues around the country and around the world, in fact. And we are asking, can we implement those in small tests of pain, determine whether there's a signal for improvement against these predicted outcomes, and then use that to either expand or pivot the next intervention. So we've essentially learned how to distill all this data to create insights. We have built a robust quality improvement team that uses the Deming wheel and the chronic care model, the model for improvement, to measure and determine whether we're improving outcomes. And we have built our model for improvement on a platform of remote patient management, recognizing that patients today spend only 0.03% of their waking hours in clinic with us, but they have to manage diabetes and make upward of 40 or more decisions a day in self-management. We have started on a path to build what I would call a virtuous cycle here, which is the patient in their self-management is generating a lot of data from diabetes self-management devices on the left. Those data come up to our cloud. Our cloud has a real-time data listening engine, and we can create alerts or notifications to the healthcare team about patients that are at particularly high risk, and then use that to drive remote patient care through text messages or video microvisits via telehealth or telephonic care. We have learned how to predict 90-day change in blood glucose control, so rising A1C. We have a model that creates a risk-enriched population, over 1.5-fold risk-enriched, that allows us to pick people out who are very likely to have deterioration in blood glucose control so that we can offer them the opportunity to participate in alternate pathways of care. And you can see in the lower right here that we've started by delivering remote patient monitoring via frequent home telehealth contacts and data sharing. We've piloted a peer mentorship program, and we're testing multiple digital therapeutics. We have similarly developed a model that we're submitting for publication this week, actually, to predict hospital admission for the major complication of diabetes, diabetic ketoacidosis, which is sort of like analogous to an asthma attack in asthma. And these are preventable admissions. So we have a model that performs very well and allows us, again, to take a rank-ordered list of individuals by risk and start working the list every month in clinic to see whether we can offer people something different than they're getting today. To drive all this, we've created a data mart. The data mart helps us to automate data collection and sharing with our external partner. We get standardized and repeatable visualizations that standardize data across the many sources that we're importing. And then it empowers cohort selection, and we're actively building this out. So I'll show you what we've done and where we're headed. I came to our advanced research compute team at Children's Mercy, and I built a data science team at Children's Mercy and said, we'd like to take data from the Cerner EMR universe, from REDCap, which is our patient reported outcomes tool, from all of these sources that you see in orange. that make up the major sources of diabetes self-management device data. And soon we will add to that Garmin health data, where we'll be piloting the use of Garmin fitness wearables in our youth, so that we can incorporate that novel type of data into our prediction models. We bring everything into a data lake structure and then operationalize it into a standardized set of tables. And then we've also created a de-identified research layer that reduces our regulatory burden for asking and answering questions that create generalizable knowledge. We think this is replicable. We think this is disseminable to other diabetes centers. We also think it's disseminable across the spectrum of chronic care and not specific to diabetes. This is a data type and source agnostic data mart. I won't go into in detail, I'll skip over this, but this just talks about some of the resources that we've created and the approaches we've taken in Microsoft Azure. So our approach to improving outcomes looks like this. This is basically our process model. We select an outcome, we develop a predictive model, we design a change package, a standardized tool in quality improvement work or implementation science work. We select ideas for change by bringing together a panel of experts to curate ideas from across the field. We rank order them and select ideas one after another and put them through the Deming wheel to plan, test, and then act on those. And then ultimately, we are creating what we call a change package plus to disseminate to other diabetes centers that not only shows them how to elicit change, but what has worked so far for us, and provides them a model for predicting outcomes the way we are. These are a few examples of interventions we're testing. We're testing both academic and commercial interventions. Switch is an Israeli company that has developed AI for the mobile phone that uses reinforcement learning to nudge behavior to help you achieve your health-related goal. So they can tune the content, timing, frequency, and tone of voice of text messages, and they can tune the goal, right, the bar that you're trying to reach each day to optimize the chances that you will take action toward your health. They've shown this can replicate some outcomes, for instance, in weight management and physical activity against the CDC's diabetes prevention program. So we think we could use it to, for instance, fine-tune nudges to help adolescents optimize their ability to dose insulin at meal times, which is a big problem that we face, or to become more physically active, or to monitor glucose without fail, et cetera. And then Dexcom is a continuous glucose monitoring company, and they have a cool set of mobile applications where a patient can see their glucose profile on their mobile phone. They can fling that to their loved ones' mobile phones, but now we can create a sort of air traffic control tower where we can see a dozen or 100 kids' CGM profiles on a daily basis, and we can use that to drive something totally new that we're calling just-in-time adaptive diabetes education, where our educators may text message with kids based on patterns that they're seeing in their continuous glucose profile. And again, I won't go through this in detail because I want people to ask questions, but we're deploying a couple of behavioral economic interventions to pay kids for certain activities, like bolusing for their meals. We have developed a mobile application ourselves for parents of preschool children to provide developmentally tailored education about diabetes. That includes things like behavioral parent training to try to get the sort of behaviors from your child that will help them be successful in diabetes self-management. And you can see here that we've got a long list. So we take things through a pipeline. We nominate ideas. We've got a 12-member stakeholder advisory committee that helps us prioritize those. Some ideas go through a quality improvement pathway where we just operationalize them clinically. And some of them, for various reasons, will go down a research pathway because we want to conduct a pragmatic trial that may create generalizable knowledge, or because they're using some technology or tool that by policy we cannot implement in clinical care at Children's Mercy, but in the context of a consented research study, we could. And here's just an example of one of those. Happy Bob is an app developed by a Finnish company, and Happy Bob is a relational agent based in psychological theory that provides motivational statements to go along with somebody's continuous glucose profile. And this has been shown to increase engagement. People are looking more and reacting more to their glucose profiles. We ultimately want to achieve a smart system where we can listen, create actionable alerts, and then offer a whole toolbox full of interventions that might help a person achieve their health goal. And we hope in the end to vertically transform diabetes care in this way. So that was a lot, but I'll pause.
It's amazing to me just how robust this is. You've collecting data, just the data collection standpoint from the variety of sources that you're getting is itself a complex operation, but then being able to digest it and stream out something meaningful in terms of intervention is key. How do you stay kind of on top of all those downstream technologies and so on?
Well, I have a whole team. So we've received some generous funding from the Helmsley Charitable Trust. So I have a research team that consists of 3 or 4 people. I've got a data science team with an additional 4 people. And then I've got a quality improvement team that has 5 people on it. So we have a whole team that are curating and outreaching to colleagues and companies across the country to understand what interventions are out there that we might consider testing.
Others from the team, welcome your questions.
I have a question. I'm particularly interested in this long tail problem that you mentioned at the top of the presentation. And, to what extent do you think the regulatory issues, the FDA regulatory issues, kind of keep that, problem from going away, really? I see regulatory issues as a major factor in the inability to adopt long tail technologies.
Yeah, so to the degree that those technologies are providing decision support or are actively diagnosing or treating disease, right? And there's a very specific definition, obviously, that the FDA has for those. Mm-hmm. You're absolutely right. We're very limited and the regulatory burden is very high. But the space that we're working in, you have to remember, is around nudging behaviors and around improving self-efficacy by optimizing education and understanding about disease self-management. And really, when you're working in that domain and not in the domain of providing direct decision support, should I take my insulin now? How much should I take? You're not in the realm of the FDA. So, there's a lot that you can do that's still a class 1 device, or even not considered a medical device defined mobile medical application.
How much research is required in order to get reimbursement for this type of nudging solution?
Yeah, so this is a really interesting thing. So CMS in 2016 started providing CPT codes, billable codes for chronic care management. And chronic care management really opened the door to continuous care in chronic disease. And then in 2019, CMS released codes for remote patient monitoring. So you heard me refer to that. And remote patient monitoring allows one, if a patient is sharing a physiologic signal from a sensor-based medical grade device, if a person is sharing a signal on 16 days out of the month, then they qualify for billing if you're monitoring that data. So you can bill for the act of monitoring. You can bill for the first 20 minutes of interaction, and you can bill for the second 20 minutes of interaction. So now you have a billing ecosystem that really supports continuous care, where in the past, we were reactively fielding a lot of phone calls from families and not getting paid for any of it. Now we can proactively connect with families between clinic visits and get paid for it. And I will say that our goal by the end of 3 years of this project is to identify a path towards sustainability, which is probably the reason Matt asked me to come talk to this group, because I am not a business person, right? I'm an academic researcher, but we are trying to figure out how to turn this into a sustainable entity, perhaps even independent of Children's Mercy ultimately, but spun out of Children's Mercy, that either as a for-profit or not-for-profit would allow us to provide a service to diabetes centers around the country, or to chronic care delivery organizations around the country.
So you have to have a device that has like a DME cert in order to
for remote patient monitoring.
Remote monitoring. Okay. Okay.
Yeah, it must be an FDA cleared device. Yep.
I'd like to ask Dr. Clements a couple of questions, if I may.
Yeah, please.
Dr. Clements, this is fantastic. I really, really appreciate and respect what you're doing here. I'm intrigued by a couple of things. First, specifically, you mentioned the metabolic memory hypothesis. Could you say a little bit more about that? What ages might we be talking about here, at least in the diabetes case that you're familiar with? And I assume that the same hypothesis would apply to other diseases.
Yeah, it's a good question about whether it applies to other diseases. We only know that it applies to glucose, but it appears both from wet lab experiments, right, cells in a dish, animal experiments, and epidemiologic studies, the most important of which was the EDIC study, which was a follow-on study from the Diabetes Control and Complications trial in the 1980s, that poor control or suboptimal control, I don't like to use the word poor, but suboptimal control early in the course of disease raises risk in a persistent way, even after one improves disease control. So, in the EDIC study, after the DCCT was completed, they followed people for an additional 10 or more years, and they found that while there was a difference in control between the people who underwent intensive diabetes management, right, they achieved a better A1C over time, and people who achieved or who were in the control group who received conventional therapy who had a higher A1C. Well, at the end of the DCCT, there was a crossover effect where the people on conventional therapy, many of them converted to intensive therapy. The people on intensive therapy were no longer in the trial, and they weren't monitored as closely as they had been before. And there was a regression to the mean. Everybody's control sort of met in the middle. But what you found is persistently for a decade and more after DCCT, that the people who had been in the control arm, who had the higher A1C early on, they still had a much higher rate of microvascular and macrovascular complications.
So is that something that can be measured for any given individual?
It's difficult to measure. It's hard. I don't think we have the methods to do it. I think that a lot of work needs to go into biomarker and epigenomic research, right? Because there are probably epigenomic changes that would be signals for this, but we're not there yet. The field is very young, and I think it's a difficult problem to solve.
Huh. Would that relate to, well, I guess the basic question here is, how is diabetes often not detected early enough in childhood in some cases? so that the wrong memories are developed, and it's hopeless in a sense to improve things from then on.
Yeah, so type 2 diabetes has a pretty insidious onset and can take a while. But type 1 diabetes, it's a little bit tricky. So we divide type 1 diabetes now into 3 stages. And stage 3 type 1 diabetes is what we often think of as the onset of the disease, where your glucoses are persistently high. And that has a pretty precipitous onset in type 1. However, type 1 is, stage 3 is preceded by a period of silent autoimmunity, where the immune system is causing inflammation in the cells of the pancreas that make insulin, and subsequently by a period of dysglycemia, where you can start to see abnormalities in glucose control emerge, but they don't quite meet the definition of diabetes yet. And that can happen for years.
My other question then is the disease agnostic aspect of your project, really, the data collection and the model that you're putting together, the process that you're putting together. Could you say a little bit more about what other diseases, pediatric diseases, you think this might be relevant to?
Sure.
What's some low-hanging fruit there?
Yeah, well, so, weight management, right? Obesity is an epidemic for youth and adults, and, being able to monitor physical activity in youth and diet in youth using remote approaches, and then providing care and using predictive analytics to, identify potential negative outcomes in the near future. That would be one. Our own cardiology program at Children's Mercy has the CHAMP program that I'm sure this group has probably heard about in the past. And I know the CHAMP program has been very interested in getting in front of problems and predicting outcomes more and more. They really have the remote patient monitoring down, but they're looking to be able to predict outcomes. And then, any chronic disease, so ulcerative colitis, Crohn's disease, other congenital heart disease, let's say rheumatoid arthritis or juvenile idiopathic arthritis, right? You name it, like any chronic disease that you can name in adults or kids would be amenable to this approach of predicting outcomes, of rapidly testing different therapies on a platform of remote patient monitoring. And the whole goal is really to drive innovation faster. It takes $5 million in 5 years to run a clinical trial typically. And, I've just learned in my career that we don't have that much time to wait, especially when we don't have to meet all the regulatory burden of the FDA for an intervention as simple as a nudging intervention on a mobile application.
Well, one of the things that's impressive about what you're doing, it was you did present an awful lot of stuff there in a pretty short period of time. But one of the things that struck me was the way you are using real world data, and there's a growing acceptance by the FDA and others, including ICER and the HTA people, of real world data, if real world data can be made a little bit more systematic. Yeah, that's the impression I have.
Well, there is an initiative called CDISC that is globally trying to make clinical trial data and real world data more systematic and comparable across sources.
Yeah. Well, thank you very much.
No, thank you. Happy to field any questions offline after as well.
That's great. One of the things I think that matters to us at sort of a macro level here is that understanding of using remote patient monitoring as kind of a foundation to intervention, and understanding that there are really different channels to what we have tried to call telehealth in many cases, that this is a much broader field than just having a video conversation with a practitioner, that in fact you can have an always connected model that does things asynchronously.
Yes, so you
matters
can
a lot.
You can use text messaging or patient portal messaging, email, phone calls, video calls, synchronous, asynchronous. It doesn't have to be the healthcare provider. It can also be skilled allied health staff, which makes it distinct from telehealth in a lot of state regulatory environments.
Yeah, it's sometimes it gets down to being a matter of definitions, but we certainly here have always tried to uphold the broader definition of what it means to be connected and to be kind of where people are, both in terms of geography and in terms of status.
Yeah. Well, I really hate to do this, but I have another meeting here at 9:45 that I'm going to have to make a transition for.
Okay.
If there are any final questions, I'm happy to take them. I really appreciate the chance to talk to all of you today.
It was great to have you, Dr. Clements. Thanks so much for making the time. As John Birch mentioned, there's just so much complexity to what you're doing. It's just fabulous to see that much going on in the community, and to have you be able to speak to it for us. We really appreciate it.
No, thank you. And thanks for all the great questions. Have a great day.
Bye now.
Bye-bye.
Okay. Next month, we'll be looking forward to a presentation from St. Luke's and Steve Kropp and Dr. Denton Shanks in terms of their telemedicine. It's a field that everybody knows has grown dramatically under the epidemic or the pandemic, and KU saw their usage shoot from a handful to thousands very quickly, and have a forward-looking view as well as to where things can be going from here. We'll also have a presentation on from another one of the accelerator groups that will be looking specifically at how images are interpreted in the medical imaging field, and we'll understand more clearly about their work. It's a group called Gradient Health, and we'll understand a little bit more about how they are using AI to interpret images for medical imaging. So, a lot more.
John?
Yes.
Sorry. Hi, John. Sorry. I was just going to go in 2 cents here with after Dr. Clements' talk. I mentioned I'm the Director of Research for the Heart Center. So any questions anyone has about the CHAMP program that he mentioned, I'm happy to help with that. But also to go into a little more depth of what are the questions he answered was some of the other groups that we're talking to, some of the chronic diseases or chronic health determinants would be feeding issues, especially in children with G-tubes. Previously, it's the work that we've had to do with bringing those children in to get them off G-tubes and to oral feeds again has been a long, tedious, and sometimes a process that has not been successful for these patients. And so we are working through cardiology because many children with cardiac disease also have multiple other chronic diseases. And so working with that other population to see about speeding up that oral feed, because the sooner you can get them to have oral feeds again, the sooner you can stimulate that the oral suck and the oral sensation, the better for the GI of the child. And we have had amazing work just in a few children that we've already just tried it out preliminarily on. So, but yeah, there's tons of different groups that we've worked with. So happy to answer any questions people have. So.
Sure, that's great, Jenny. Any thoughts from anybody in the team? CHAMP, just for those who may not be aware of it, is, and Jenny, you can correct me here, but it's a remote patient monitoring system that for children who've had cardiac surgery and need to be released to the home, and the ability to pick up more quickly on any changes in their condition so that they can be brought back and have a strong intervention rather than expiring at home.
Yes, for certain populations of children, especially those with single ventricles, so only half of their heart is pumping out, they previously, and I say previously being, last 5 years, not that long ago, honestly, across the country, the mortality rate between these stage procedures, between the first and the second, was anywhere from about 25 to 30% mortality. And we are at, across 12 different sites, we have a mortality rate of 3%. And these other sites are still working on trying to get it down. Some sites are down to 12%. We have really done a lot to really emphasize the need for caregiver, hospital caregiver evaluation of patients on a daily basis via video. So, Elliot, your facial recognition work, we are very interested in that kind of stuff. We also have looked into things like that, especially for things like color change or retractions, things that if you're a mom looking at your child, thinking about any parent, you see your kid grow and everyone's like, wow, he's grown so much. And you're like, yeah, really? I hadn't noticed, So when you see a child every day, you might not necessarily see the change, but when a caregiver sees that video in their 15-second videos, and they see a different video every day, they can compare to other previous videos and see those subtle changes that a parent might not see and bring those kids in for intervention on a faster basis.
We'd certainly like to talk to you about what we've done, Jennifer. We spent the better part of a year researching artificial emotion intelligence, the state of the art, which it's really an emerging tech still. And we have, to add complexity to the solution, the aged face is an extremely novel use case in both gaze detection as well as emotion detection using facial models, because there's no baseline for the aged face. So it's fascinating. There's a ton of bias in facial recognition tech already. And unfortunately, like the older our population gets, the larger that bias becomes unless we start studying it more. The younger face, though, actually has some interesting particularities as well. But would love to talk to you more about what we're doing.
Yeah, that would be great. Thank you. But yeah, we are very interested in collaborations with groups. And yeah, as you said, this is such an emerging field, and trying to find others that are doing these same things, and to find people that are IT groups that specialize in it. Very, very limited work is being done. And so, yeah, we are definitely learning about that.
Oh, that's great. I'm glad that we had that discussion.
Mm-hmm.
Other thoughts or points or announcements for organizations you work with, whatever makes sense. We have a couple minutes left. I'd be happy to open up the floor to anyone who has anything to share. One thing that I noted in the invitation for today's meeting was that there would be a fundraiser that would benefit Casey Digital Drive that was being sponsored by the Health Informatics Management Systems Association. That's HIMSS. Unfortunately, due to the growth of the Delta virus, we have together jointly decided not to host that event, but we'll be doing kind of a fun trivia noontime event that I'll send out in the next announcement, and hopefully people from this group can join in that as well. So with that, I'll just again remind you that that September fundraiser is not happening, but otherwise look forward to having you all back here again for the September meeting, and look forward to great discussions and in your wonderful participation. Thanks so much.
Thank you.
Bye now.
Thank you.